time it is. Marvin Devine, Huber, Axel, and you know how we do. Yeah, I got the juice. Big game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. Let's go. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, XL, and Huber, way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we when we link up. Let's go. Yeah, I got the
Good morning, good afternoon, or good evening, wherever you're watching this broadcast from. Welcome to another episode of Kidney Hub East Africa. I am half your host, Steve the Kidney Nurse. Welcome. And I sincerely mean that, welcome. And I want to welcome our family from TikTok, YouTube, Facebook, wherever you're watching. Thank you for joining us today. We finally got Brother Moses back after 2 shows. There's been many hurdles, and Brother Moses is back today. And today is a serious topic that we talked about before. But as I mentioned, many people, especially in East Africa, all over the world, diagnosed with kidney failure every day. Right now, as we do this show, somebody in this world is being diagnosed with kidney failure. Now, with kidney failure, in order to be treated, it has to be some way to get to the blood so it can be clean and fluid removed from it. And how do we achieve that? Through what's called a vascular access. Now, vascular access is a way to reach the blood vessels for hemodialysis. Now, we have 3 types, but it's not just hemodialysis. You have peritoneal dialysis. So now you have a peritoneal catheter. But you have a fistula, a graft, and a catheter, whether it's a subclavian catheter or PD catheter. Now, with this vascular access complications can arise from the methods used to establish vascular access for hemodialysis and peritoneal. Now, we're going to talk about some of them complications today, So let's get started. But first, let me bring on our brother from Kenya, who's been through a lot of challenges, but he's here today as half the host of Kidney Hub East Africa. Ladies and gentlemen, bring on our brother Moses Kennedy, also known as the Kidney Ambassador. Here we go. Brother Moses, welcome.
Thank you so much, Brother Steve. I'm glad you are here today, and it's a wonderful topic indeed, Brother Steve. We've talked about this topic, but we can't stop talking about this topic again. So I'm really glad. I want to emphasize that even as much as we talk about a topic, we are just trying to reach new viewers who might need this crucial information. As you know, dialysis treatment is a medical emergency, and it is a global rising pandemic. Back to you, Brother Steve.
Are you right about that, Brother Moses? I'm glad to see you. And speaking of this topic that we're about to talk about, how is everything going with your access? Because you recently got a hemodialysis graft put in not too long ago. But before you talk about that, let me just explain to our viewers what a graft is. A graft is a piece of man-made blood vessels, the tubing, where they connect one end to an artery and another end to a vein, and is used to get access to your blood for hemodialysis. But how is your access coming along, Brother Moses? Because we know you took a trip to, I think it was K&H Hospital. And
yes.
And that's where you met one of our followers, Tabitha, I believe her name is. And you went there for evaluation, get checked up for your graft, which you haven't had in a while because you've been using the catheter. And the catheter is a plastic tube placed into a vein in the neck, chest, or groin. And they may be used for a short time, or they could be used for a long time. And that's what you had before going to get this graft put in. So tell us, how is the graft coming along?
Oh, well, Brother Steve, let me just take you back from surgery room. When I got into the surgery, I was prepared to actually have a graft. And then when I came out from the surgery room, graft working perfectly, I could see the graft buzzing so nicely. And when I went back to Kisumu from Kenyatta National Hospital, what happened is that maybe because of inexperienced staff, they were unable to use my graft because they kept on buying time with me. And then my physician told me that maybe the nurses are not comfortable and they are not experienced about using the graft. So when I went back, initially, my physician also thought my graft was not working, but it wasn't buzzing, but then it was working. So it was not easy to to evaluate, because for most nephrologists are physicians. Now I had to be sent to a surgeon, cardiothoracic surgeon in Kenyatta National Hospital. And then I got reviewed by the same surgeon who did it, because we had even made close contact. We became friends. I was just able to call while queuing. So when I got in, I was checked. It was buzzing perfectly well. Now, Brother Steve, to make sure that I was satisfied, they went as far as admitting me to Kenyatta National Hospital so that I can get a specialized an appointment dialysis session. And Brother Steve, it really worked so nicely. I was surprised when I called back my
they
doctor.
stuck it at the hospital. They stuck it and used it at the hospital.
Yes, they stuck it with with gauge 18. It was
18 gauge.
I mean, yes, 18. So
that's a small needle.
Sorry?
That's a small needle.
Yes, they used gauge 18.
I've never seen an 18 gauge needle used for dialysis.
And then I was advised now I can use 16.
Okay.
So
they moving up.
Yeah. They did that, and it was perfectly well. Imagine a situation where the graft is not buzzing, you can't feel it. But the surgeon laughed at us. He said that the graft that was placed was a little bit thick, so it could not buzz as people would expect it. But it was buzzing initially. Now, I left that place a happy man. When I went back to Kisumu, still they could not use it because they are trying to arrange someone to assist at my place so that they get acquainted with the graft. That is the challenge, and they never thought of first removing my catheter. So currently, I still use catheter, but I'm blessed I have to access catheter and graft. So this time when I go to review in Nairobi 26th, definitely I'll use my graft. But then at the moment, I'm using the same catheter I've been using for the last 7 years. So basically, it takes cleanliness and cautiousness to have your access up to date, Brother Steve.
Brother Moses, I'm listening and I'm saying to myself, if the staff at your unit is inexperienced or can't do it, why maybe when you go back, had a surgeon draw a diagram, have a picture of an arm, and draw the diagram where the graft is, and show them where to stick. And you bring that paper back with you and say, hey, this is where, you got a picture of the arm, not your arm, but a regular arm, and he draws the graft on that picture, right? He draws the graft and say, here, you stick here. That's what a lot of surgeons do here for people who may have trouble accessing that person's, whether they got a fistula or a graft. The surgeon sends back consultation notes, but may have a picture and say, here, you stick here, and have it drawn so we can have it for our records and we know where to go. And you can ask him to do the same thing for you, because it's no way that you go to one place and they got success with it, and then you go back to where you live, your town, and they can't even get it. That's not fair to you. And so I would suggest, again, when you go back and see that surgeon, or if you know him, like you said, maybe you could call him up and ask him if he could draw a diagram on the arm to show the staff where exactly where to go and maybe how deep or not deep the access is.
Oh yes, the problem basically came in when the staff are just trained well, but then they haven't had the opportunity or the exposure to to handle a graft,
Really?
because they can do fistula very well, but they haven't had that exposure to to do grafts.
I'm sure you're not the only one that got a graft.
At my place, well, basically, it's almost me around.
But do they have
All
other
it,
clinics? Like, does that staff
yes,
move around and work
they
other
don't have
places?
other clinics. Other clinics, they don't have anyone with graft.
Really?
Yeah, what? Surprisingly, brother Steve, 90%. I mean, about 80% of dialysis patients, they are not using. They are using catheters
What?
because yes, it is high. Majority are using catheters. So it is possible. What is in Kisumu could be a replica of other places, other towns.
Wow.
Yes.
Wow. That I mean,
Well,
that's a recipe
so
for a
not
high rate of infection.
because failure rate is also very high on maturity of fistulas and
Right.
grafts.
And see, that's
Yeah.
why here, when they fail, when they fail to mature, then the doctor or the surgeon puts in a graft. That's the second use access here. First, they're going to try a fistula to use your own
Hmm.
veins because they say that's the best access to use is using your own veins. Then if that doesn't work, it's the graft, the man-made tubing, something like you have. And then the last is the catheter. So wow. So let me just
So
discuss.
basically, you know, uh, when I left Kenyatta, there was a solution. They wanted me either to relocate back to Nairobi, or they try to find out how they can help me. But again, going back to Nairobi will mean another cost. It is not high cost of living in Nairobi generally for a patient
Right.
like myself. But then we did an agreement that they are going to contact also some nephrologists to come to my clinic and try mentor if the clinic owner allows that.
I wish I
Yeah,
could
that
come
was
over there.
the long term.
I
Sorry?
wish I could get over there and see if I can help out.
Basically, this is what we were supposed to do when you are to come. But then I know things will shape up.
Yeah, yeah.
Yeah.
So let's talk about Brother Moses. Before we get into some of the dialysis access complications, let me just talk about the three different type of access and then why a vascular access is important. So again, but the vascular access is a way to reach the blood vessels for hemodialysis. And now there are four types, but in this one we're talking about three. The fourth one is peritoneal, but the three are a fistula, where your artery and your vein are sewed together, and then the blood from the artery goes in that veins and hopefully expands that vein in 6 to 8 weeks and hope that we can stick needles in it. And we're talking about needles that look something like this, but a little smaller. And this access, the fistula, is the longest lasting access because it's your own veins. Then next, if the fistula doesn't work, then they want to put in a man-made tubing, flimsy type of material, Gore-Tex graft type of material, tubing a little softer and flimsy like this, and they put it in your arm. It could be up in the upper part, lower part, and almost similar to like a horseshoe shape. And so, and then you got the catheter. This is one type. This is an IJ, meaning jugular. And this one, see how short it is, goes in the side of the neck in the jugular vein. It's just like this, and they suture it down. And this gives us quick access to the blood. And then you have the regular, here we go. We got the regular catheter. Chest catheter goes right there, or like they say, it could go in your groin. So why is the vascular access important? People consider that their lifeline, because if you don't have no vascular access, there's no dialysis. Is that correct, Brother Moses?
Absolutely true.
That's why it's important to care for this access, to make sure there's no infection, that it's being clean, whether it's your catheter or they're using your arm. So let's talk about what happens in surgery, and then we're going to get into some of the complications. Now, you might say, what happens in access surgery? Because I'm supposed to get an access put in. And again, a lot of people don't get privy to this information. They go in unknowingly what's going to happen when they got to see the surgeon. So normally what happens in access surgery, a fistula or graft is most often placed in the arm. But sometimes it could be in the leg. A lot of people didn't know that. So I would ask your doctor, some people are real vain. They're like, I can't have it in my arm. I won't be able to move, or I don't want that in my arm. So I've seen some people get it in their thigh, in their inner thigh area, either a graft or a fistula. So when you go into that surgeon's office and they do what's called the vein mapping, and they say you have small veins, ask them about the possibility of going in your leg. Now, surgery for a graft or a fistula is often done with local anesthesia. They might, I don't know, they may put you under general. And it's normally on an outpatient basis. Now, they may prescribe you medication afterwards for like pain meds for mild to moderate pain. And just like Brother Moses, sometimes you may have swelling of the affected area that may occur for a few days or a few weeks. Brother Moses, can you share what you experienced before we get into some complications with access surgery?
Oh, yes. Basically, after surgery, the arm swells. Mine swelled for an entire 2 weeks. I was trying to put it at a raised position, and that is how I was advised. So sometimes it used to reduce, but towards dialysis treatment, because it could have some kind of edema because of water in the tissues. But then it was very painful, and I used to take care using some painkillers. Now, uh, I would sleep and wake up sometimes just to relocate my arm. So it wasn't something comfortable until it got healed, that the arm went back, but the physical line appearing inside the skin for the graft is well visible. Yes.
Wow. Wow. So has the swelling reduced?
Mine reduced after 2 weeks. It got reduced completely, and it just, my hand got back to normal. But then the line, the marking was protruding where the graft is. So I have it at the upper arm. So that is where it was.
So do you check it every day?
Oh yes, even if I check it, I don't feel it buzzing. So that is why myself, I was also concluding it is not working. But when it was...
No, I'm sorry. I was going to say, have you thought about, I know money's tight, but you could possibly find a stethoscope that they listen, when they listen to your heart rate. You have one of them, you can put it up against there and listen to the bruit.
All right, I can ask one.
Yeah, or you can put it up. See, if you could put your arm close to your ear, like when you don't have the sweat jacket on, and you just got your shirt, you could put your access to your ear, and let's see if you can listen for it. That's how
I've tried
you don't
that.
have a stethoscope.
I've tried that when entire place is quiet, but I can feel it from afar. Can just feel it from far distance. But one point. At one point. Yeah,
so
but when I went
to stethoscope.
Yes, that is actually what my surgeon used to confirm that it is working.
Yes. Okay.
Yeah.
So let's talk about.
Have you ever had experience such a throughout your practice? Maybe you don't feel by just normal feeling, but the graft is working. Is it a normal experience?
Yeah, for some people who maybe have a lot of weight and a lot of fatty tissue, their arm, yes, or maybe just their cardiac output is low. The access is working, but the flow through it could be faint, or barely hear it, but it is working. Yes.
All right. Thank you so much.
So let's talk about access complications for hemodialysis. And we're going to talk about the catheter first, because for many people, this is the access that they come in contact, their first access. For many, is the catheter for the chest or for the side of the neck. But normally, they will put the IJ in if they need to do emergent dialysis, get you situated, pull this out, and then put this in for long-term use, or until they decide if they're going to put accessing your arm. Excuse me. Now, let's talk about what a catheter is. Catheter, here we go, is a tube inserted into a vein in the neck or chest to provide vascular access for hemodialysis. The tip, which is this part right here, the tip rests in your heart. It's in the back part of the heart where this tip rests. Now, it is usually a temporary access. It is the third choice for getting access to the bloodstream for hemodialysis. For some patients, it's the only choice. For some patients, it's the only choice. And it would need to be used as a permanent access. Now, the only advantage with using this, it can be used immediately after we put it in. Once they get chest x-ray to verify the placement, make sure there's no pneumothorax, where puncture the lungs, whatever. Then say, okay, you can go ahead and start dialysis. Now, let's look at some of the complications and the disadvantages of this. And this is something that Brother Moses has to be careful about as well. Because as he said, he's still using his catheter. Now, here go the disadvantages of a catheter. Higher infection rate, number one, which can be very serious or fatal. Increased hospitalization. Does not last long, usually less than 1 year. But Brother Moses defied the odds. He said he's been having his for 7 years. May require longer treatment time because it's man-made. That's why you're going to require longer treatment time. You may not get a good blood cleansing. That's why they want to keep you on for a longer treatment time. Prolonged use may lead to inadequate dialysis. Showers, you cannot do a shower unless you have a cover over it. High rates of clotting requiring frequent procedures. And as last night, when I was on TikTok Live, I talked about this. If you're watching this, again, if you have a catheter, okay, if you have one of these and you're always going to the access center or they having issues, they can't get the blood out, telling you to cough sometime. This is one of the main reasons. You see this slit in the end of this catheter? Those slits right there, those holes. That's where the blood comes through when it's sitting in the back of your heart. And so when you have a foreign material such as this catheter resting in your heart, blood is going to attach itself to it because it's a foreign object. That's why we put heparin post-treatment. We put a heparin lock. Whatever the length of the catheter, it's on the side. It's written on the side here, very small. It could be 1.8, 1.9, 2.0. This one it has the 1.7 arterial, venous 1.7. That means the length. And so we're going to draw up 1.7 or 1.8 or 2 cc's of heparin and instill it in here and lock it. What I mean by lock it is put the cap back on, clamp it, tape it up. Now you got heparin in here to help prevent the blood from occluding these holes. And so if they don't do that, the likelihood of these holes over time, after you do a treatment, rinse the blood back, a portion of that blood, the byproduct, is going to stick around just because of what this is. It's a foreign material. Like when you get a stent and they want to give you what's that? Blood thinners. And so you may take a blood thinner to prevent clotting. No different than this. Also, another disadvantage is the risk of destroying an important vein. And see, if you look at this, and you see right here where the catheter is, and you see the heart, you see the vein that it goes in. If you keep putting catheters in there, pulling it out, putting one in, then it's a possibility you can destroy that vein. So what are some complications for this catheter? The biggest one, the first one I said on that paper, infection. And that could come from staff not changing their gloves, washing their hands, have their mask up over their nose, their nasal flares. Maybe you at home, the dressing came off and you don't know what to cover it with, so you're walking around with it exposed. I've seen people do it because they don't know. Some places it's hot and the dressing comes off because you're perspiring. All right, Brother Moses, before I move on, do you have anything you want to say about this before I move on?
Yes. What I fear also most as just other warriors is that infection, because it comes in with so many challenges, additional cost, getting hospitalization, just like you've mentioned, Brother Steve. And above all, just keeping you in hospital is also traumatizing.
Yes. And you
Back
know what,
to you,
Brother
Brother
Moses?
Steve. Yes.
And if this become infected, right, it can lead to serious complications such as sepsis. And let me tell you something about sepsis. That's a very serious condition, infection, that can possibly unalive you if it's not treated correctly. And I'm sure many warriors who had this catheter experience an infection one time or another. If you haven't, you're very lucky. And keep doing what you're doing to not get it infected. Now, The same can happen if you got access in your arm. Your fistula could come infected, especially if they're not cleaning your arm right. We got germs on our arm that you can't even see with the naked eye. And so that's why I always encourage warriors, when you go get your treatment, if they got a sink near the scale or even in the bathroom, get some antibacterial soap and wash your access really well and pat it off with a paper towel, because they may not clean your arm like they should. They may only use 2 alcohol swabs, one for one side, one for the other. And one alcohol swab is not going to clean off any germs. So at least you know you cleaned your arm yourself and you don't have to depend on the technician. Or have them hand you some alcohol pads or whatever they use to clean your arm, and you clean it yourself. To make sure you know you're doing it the right way. Let's look at another complication of the access. Something called thrombosis. Like, why are you using these big words? Thrombosis or thrombi is a clot. That's all it is. It's a medical term used for a blood clot. And in this way, in this sense, it's a clot formation. Now, blood clots can form in the access site, leading to reduced blood flow and ineffective dialysis. Now, this is more common in grafts. And you know why? Because it's a man-made device, plastic, in your arm. And when you got one end is hooked up to the artery and the other to the vein, now you got blood going through there. Right? However, what if your blood pressure drops? If your blood pressure drops, that means the cardiac output is going to drop. And that means the slowdown or the movement of blood through that graft. And guess what? You can even sleep on it. That's why we say don't sleep on the side where the access is. That can stop the movement because of the compression. You sleep on your arm, you compressing down on that graft, the tubing. And now the blood can't get through because it's compressed. And then when you wake up in the morning, that's why we say if you got a fistula or a graft, you should be checking it 3 times a day. In the morning when you wake up, midday, and before you go to bed. All it takes is a quick access check to feel. And people wake up and they go to dialysis, they don't do none of that. And you get on the bus, take you 30, 20 minutes to get there. Your pickup time may not be until 3-4 hours later. You get to dialysis and they putting the needle in and they can't get it. What's going on? And the next thing you know, they put the needle in and you see this dark, thick blood coming right here, not going nowhere. You see dark blood coming out and it's not moving. Your access is clotted. And technically, the staff is supposed to check your arm before they even put the needle in to prevent something like that happening. Because if we can't hear it or feel it, it may not be working. And then they confirm it by putting the needle in and see the dark blood. Another problem is stenosis. Like, Steve, well, all right, let me move back. I'm sorry, Brother Moses. All right, oh, and let me say this about thrombosis or clot formation. It can happen in the catheter. And it can happen with the fistula as well. It's just more common with grafts because it's man-made. And just like this, you can get a clot or something that'll occlude this, and it's not working. Now you got to go to the access center, get a procedure done, possibly getting it replaced. Brother Moses, anything you want to share about clot formation or thrombosis of the access?
Oh yes, oh yes. One thing, the doctor did suggest that I take anti-clot drugs because he was fearing could be having some kind of that clotting around my within my graft. So he suggested that by taking these drugs will keep any form of clotting that would want to form within that access. So yes, it is very important to keep on checking whether your graft is working time and again. Each time, morning, afternoon, midday, very important to check. But for my case, I also given just some drugs to take, to cushion in case that one happens, simply because the doctor was suggesting highly that I could be having that clot formation. And I've been using drugs like Rosiclot just to take care of that.
All right. Thank you, brother. Thank you for that. So stenosis, which is narrowing of the blood vessels, stenosis. And that's why many people go to the access center to prevent that from happening.
Let me just log out for a while, then in again.
Okay. Stenosis, which is narrowing of the blood. And excuse me. Hold up. Which is narrowing of the blood. Now, stenosis can occur at the site of the fistula or graft, leading to decreased blood flow and potential access failure. And there's checks that we can do to know if you're getting a narrowing. And that's why I say you got to listen with a stethoscope, because if you hear a high-pitched whistling, like a tea kettle, then it's a possibility your arm is narrowing, because that whistling and you hear from the stethoscope is coming from the pressure of the blood trying to get through that narrowing. You see what I'm saying? And so that's very common. And so for many people who got small veins, you may have that issue. Now, here's another one. Another complication that you see many patients have far as complication is aneurysm formation. Aneurysm formation. And what that is weakening of blood vessel walls. And where does that come from, or how is that derived? Through sticking at the same area each time, not rotating the site. Not rotating the site. And so you keep going in the same spot. We call that one-site-itis. And what happens when you're going in the same area, and the reason this happens, either because the technicians or the nurse feel comfortable because everybody else been going there, or the patient will say, go there, because they don't feel it. They don't feel the stick like going in when you go into a new area, right? So when you stick it, that's why we tell you to rotate the sites like you're doing a ladder, right? One finger width or two finger widths apart, one right here, two finger width, the next one right there. And then the next time, keep like a leapfrog. And this, like I say, when you do that and you stick it in the same area, that high velocity of blood that's coming through your access site from that artery is going to expand because it's weakened now, that area. So it's going to create that knot. And sometimes when you keep going in those areas, it can weaken, it can rupture, and potential blood loss leading to death. That's why we say rotate those needle sites, because it will save your access in the long run. Let me skip one of the ones. I'm going to talk about access failure, but someone on, thank you. Someone on TikTok mentioned Steele syndrome. And that's a common, and I'm glad they mentioned that. Because that tells me they know something about it or they experienced it. And for many people who are just being told that you got to go on dialysis and don't have access in your arm yet, this is another journey that you're going to have to experience. Because when you get cut on your arm and the surgeon is rerouting veins and arteries to create this fistula, you can have something called And this is a problem. Just like clotting, thrombosis, infection. This is a problem. Ischemia or Still syndrome. And what causes that, you may ask? When it comes to a fistula, using your own veins, if the anastomosis for a fistula is the junction where they surgically connect the veins. If the anastomosis is too big, it can deprive the rest of the limb of an adequate amount of blood flow. This problem may be worse in patients with vascular disease, such as diabetes. So if you got diabetes, you had it for a while, and you got to go on dialysis, and they try to create that fistula, and they create that anastomosis is big because you got small veins, there's likelihood that you may develop Still syndrome. And same with a graft. Normal arterial blood supply to distal extremity is shunted through the graft. So the blood that, when they put that tubing in for the graft, some of that arterial blood that goes for our digits and fingers, you can feel some of that is rerouted to the graft, thus depriving the distal extremity needed oxygenation. Occurs most commonly in patients with poor distal circulation before creation of the AV graft. So if you had poor circulation before they put in this access, more than likely you're going to experience some problems after they put it in. Now let's look at, before we turn it over to Brother Moses and get his input about ischemia or Still syndrome, let's look at some of the signs and symptoms of this problem. 1, the affected limb is colder distantly, further from the limb than non-affected. So what I'm saying, you got a graft, they just put in a fistula, and you experiencing Still syndrome, your fingers, they may be cold. You may see blue because no oxygen getting down to it. They may be numb, may be hard for you to grasp something. Cyanotic or blue nail beds on the affected limb, what I just talked about. Pain in distal extremity, fingers or toes, ranging from mild to severe, usually made worse or precipitated by dialysis. Now, this is a classic symptom. Soon as you go to dialysis and they hook you up, your hands become cold or they start aching. This is because the blood that's coming out is being stolen away. And you may have to say, hey, do you got something I can put over my hand, like a towel? Or we may tell you to wear a glove or a mitten. Back in the day, they used to get a glove, right? And put hot water in it at the unit and give it back to the patient, and they have it under the chucks, and they got their hand on it. And that feels good. But they stopped that because if that glove bursts, that hot water could burn you. So they don't do that no more. They tell you, bring a glove. Bring your own glove or a mitten. or whatever you have to do. And another sign or symptom is pale distal extremity, meaning if you got the access in your leg and you got still syndrome, your toes, up here, your arm, your finger's going to be pale. And a lot of times you got to go back and get this corrected. But Brother Moses, any comments you like to talk about when it comes to Still syndrome or ischemia?
Well, personally, I haven't had that experience, but then just like I want to echo what you've just talked about, the importance of being very keen in a way that when you see some signs and symptoms, definitely you should rush and seek your doctor, Brother Steve.
Absolutely. Absolutely. All right. So let's move on. We over the time. And see, we don't just cut it off as soon as time is up. We go over a little bit. The next one is access failure. This is loss of function. This can occur due to thrombosis, clotting, stenosis, narrowing, or other complications necessitating the creation of a new access. So basically, if the access failed, they try to put one in the bottom, and they did all they could. And you go back to the surgeon, he's widening this, that. He's like, we just can't do nothing with it. Next thing you know, they say, we got to go up. He's like, my God, another access try? I have seen people with access here, 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 and here. Both arms, and they finally had to put it in the leg. So, again, if you are told or suggested you go see a surgeon, you make sure you ask questions, even get a second opinion when they're ready to create this access. Also, another problem is bleeding from the access site. Patients may experience bleeding from the access site, especially if there is trauma or if the access is not properly managed. Now, if you got a fistula and you bleeding for a long period of time from that venous, and you're like, I never bleed this long before from my venous, it's a possibility that you got some narrowing going on. Because if you got narrowing going on, it's going to force that blood and cause the bleeding. Brother Moses, anything you want to add in?
Not much, Brother Steve.
All right. Okay. Also, the last one, far as for hemodialysis, is pain and discomfort. Local pain. Patients may experience pain or discomfort at the access site, which can affect the quality of life. Now, if you always getting stuck and they not getting your access, having issues, and you leave dialysis, you got pain in your arm, that can affect your quality of life. And so that's why, again, it's important to make sure you keep your access working well. You check it 3 times a day. You make sure you're cleaning it with antibacterial soap, warm water. You just don't let anybody stick you. You find out who the expert cannulator at that unit is. What I mean by cannulator, person who could put the needle in. And I even suggest maybe you should stick yourself. Learn how to stick yourself. Who are you going to trust? Yourself or some Joe Blow off the street? Even myself. You say, I may trust you because you've been doing it longer. But I can mess up too. But if you do it, if you learn it yourself, then you ain't got nobody else but to blame, but yourself. But you know you're going to do the best job possible. We try to encourage
Very
boys,
true.
yeah, to stick
Very
themselves.
true.
And it's not hard. And I know I can see some people, I couldn't do that. But I mean, you let other people do it. Anything you want to say, Brother Moses, before I move on to peritoneal dialysis complication? Anything you would like to add to what I just said? Brother Moses, are you there? Can you hear me, Brother Moses?
No, you're freezing.
Okay, you may have to sign out and come back in.
Okay.
See, this is the issues that we get from Kenya because of the data plans. But look, we're going to go right into peritonitis because, like I said, we over the time. But this is a peritoneal dialysis access complication. It's peritonitis. That's an infection of the peritoneum, which is the lining of the abdomen. Now, this is a common and serious complication of peritoneal dialysis. For those of you, it's like, let me try to do peritoneal, right? That is a serious complication. And it's also common, often caused by bacteria entering the peritoneal cavity through the catheter. Number 2, catheter malposition or dysfunction. You got improper placement. The catheter may not be positioned correctly, leading to inadequate dialysis or difficulty in draining the fluid. So you don't hear a lot about this because a lot of warriors may not share this. But if I'm telling you, if you got a peritoneal catheter, PD catheter, and you just started and the PD nurse didn't get a chance to go through this with you, now you know you have another place to come to get information. Number 3, exit site infection. Infection at the catheter exit site, meaning where it's coming out at. Now, this can occur where the catheter exit the skin, leading to localized infection, or germs could get on that catheter and go under and cause a tunnel infection. And then again, that's the next one. You back, Brother Moses? You can hear me?
Yes.
Okay.
Yes.
And then that's the next one. Tunnel infection. Infection along the catheter tunnel. This can occur in the subcutaneous tunnel where the catheter runs from the exit site to the peritoneal cavity. Another problem, dialysate leakage. Fluid leakage. Dialysate may leak from the catheter site or into the surrounding tissues, leading to complications and inadequate dialysis. Number 6, abdominal complications. Hernias or fluid accumulation. Patients may develop hernias or experience fluid accumulation in the abdominal cavity, also called ascites. And then you got hypotension, low blood pressure, rapid fluid removal during dialysis can lead to hypotension, which may cause dizziness or fainting. And that can happen on peritoneal as well. And so, as we conclude this topic, complications from dialysis access can significantly impact a patient's quality of life and the effectiveness of dialysis treatment. Regular monitoring, proper care of the access site, and prompt management of any complications are essential to ensure optimal outcomes for patients undergoing dialysis. Now, I encourage you, if any complication arises, consult your dialysis team, your vascular surgeon, or your nephrologist immediately for appropriate intervention. Brother Moses, any final words you would like to say before we end this broadcast?
Oh yes, just getting down to know the type of access you use, how to take care of it, and then basically in event of any red signals, whom do you seek help for? It is better to get the right person and discuss with especially your care team. And above all, I want to encourage you, each warriors, to try to understand and learn about the type of access they are using. Thank you, Brother Steve.
Well said, Brother Moses. Well said. And, I hope that they are able to start using your site at your facility so you can get some great KT over Vs and get rid of that catheter, because I'm sure you're probably tired of it. 7 years with it.
Definitely. I'm really tired. I'm tired of it. I'm just planning to get rid of it. Yes.
All right, Brother Moses, any last parting words you want to say to our brothers and sisters, kidney warriors in East Africa, about this topic we talked about tonight, access complications, what you should know?
Oh yes. Basically, to everyone out there, especially kidney warriors from East Africa, that complications is part of dialysis treatment, and that is the side effect of having that treatment. And then above all, we must also prepare for any form of emergency, any form of eventuality, should you have emergency. That is quite common, and we have to accept that as warriors. So yes, very important to get educated. Self-education is the best, and take care always, as we have just discussed. Thank you. Back to you, Brother Steve.
All right, Brother Moses. So, with that being said, we're about to close the show. We'd like to thank everyone for tuning in who watched. Unfortunately, we didn't get any questions asked on the YouTube and Facebook side, but that's okay. Keep coming back, because there's no other broadcast on that goes in depth into kidney care such as this broadcast with Brother Moses and I. And so with that being said, again, we'd like to thank everybody for tuning in. And if you have any questions or any show suggestions, you can always reach out to myself or Brother Moses through Facebook at the FIGO Initiative, or Steve the Kidney Nurse Facebook page. Both are on Facebook, okay? And please share this broadcast and look at the replay if you get an opportunity, if you missed us in real time. With that being said, thank everybody again for tuning in and watching us, and we'll see you next time for another episode of Kidney Hub East Africa with Brother Moses Kennedy, also known as the Kidney Ambassador, and Steve the Kidney Nurse. Thank you, everyone. Goodbye. And Brother Moses, take care, and I'll definitely be talking with you real soon.
Thank you. Take care too, brother.
All right. Thank you, everyone. Wait a minute. Here we go.
Hello, I'm Darren. We have breaking news. More than 600,000 Americans have kidney failure. While the number of people with kidney failure is enormous, the number of people with its precursor, chronic kidney disease, is staggering. An estimated 31 million Americans, or about 10% of the US population. Diabetes and hypertension cause 2/3 of all cases of kidney disease. 1 out of every 3 Americans is at risk for kidney disease, and kidney disease is now among the top 10 causes of death in the United States. In addition, 9 out of 10 people with early to moderate kidney disease don't know they have it, putting their health in jeopardy. Are you at risk? For more information, contact urbankidneyalliance.org. The life you save may be yours.